Well, it's a great pleasure for me to introduce our first speaker to you. He's currently a senior attending physician on the staff of the North Shore LIJ, holds a teaching position on the NYU School of Medicine faculty, and has participated in many research projects in the field of medical oncology as the principal investigator. He's published several papers in nationally recognized journals. He brings over 25 years of clinical expertise to his patients, who include many NET survivors, and we are absolutely thrilled to have him here today. Please welcome Dr. Hal Gerstein.
Thanks to Rob and Marianne for their yeoman's work in producing these conferences over the years. Usually they occur in November. It feels like November in here. So maybe we can turn off some of the air conditioning. My job outside of these conferences is to bring cancer care to my patients. I'm one of these guys that doctors refer to as working in the trenches. I'm honored to be included in the list of experts, but I am no expert in neuroendocrine tumors. I do provide care to my patients, but I rely on the experts that you will hear later today on their research, their words of knowledge in what to bring to my patients in my office and in the trenches. What I'm going to do today is try to give you an overview of neuroendocrine tumors, what they are, what they mean, how we go about looking for them, diagnosing them, and then we'll switch over to our experts to tell us more about some of the newer treatment modalities that we have. What are neuroendocrine tumors? Neuroendocrine tumors are cancers, no doubt about it. Some are slow growing, some are rapidly growing, but they are cancers. We all have heard the term carcinoid cancers, carcinoid tumors. All carcinoids are neuroendocrine tumors. Not all neuroendocrine tumors are carcinoids. NETs arise from the enterochromaffin cells located in neuroendocrine tumor throughout the body. These are cells that grow as we develop from a fetus. NETs may present either as functional or non-functional tumors. The symptoms are very heterogeneous. And the symptoms, if patients do have symptoms, reflect on what organs the cancer may arise in, such as thyroid, GI tract, including pancreas, the adrenal gland, lung tissue, or Merkel cell carcinomas. NETs, as Rob mentioned, the incidence of NETs are increasing very rapidly, most commonly in the lung, in the small intestine, and the rectum. The incidence is also increasing faster than other malignancies. And it's not isolated to the United States. It's increasing all over the world. Why are NETs increasing in incidence? We don't really know. Perhaps because we have better diagnostic techniques. Perhaps because we're more aware of the diagnosis and we screen more frequently for NETs as well as other cancers. And perhaps there are some environmental factors that we're just not aware of yet. Maybe some of our experts will shed some light on that. So some NETs, as I said, are carcinoid tumors. They can be symptomatic or asymptomatic. The problem with the diagnosis is in patients that are asymptomatic, these tumors can go undiagnosed for many, many years without obvious signs or symptoms. If they have symptoms, those symptoms are caused by peptides that are produced by these tumors. And depending on the location of the tumors and the peptides that are produced, then we can decide or try to classify where the tumor is coming from. The three main categories that we use are foregut tumors, midgut tumors, and hindgut tumors. Foregut tumors develop in the respiratory tract, the stomach, the first part of our small intestine, and the pancreas. Midgut tumors develop in the lower two-thirds of the small bowel, the appendix, and the ascending colon, or the first part of the colon. Hindgut tumors occur in the lower two-thirds of the colon or the rectum. Gastrointestinal and pancreatic nets are by far the most prevalent neuroendocrine tumors. A distant second are lung tumors. Interestingly, nets are the second most prevalent type of GI malignancies, and nets are much more common than the run-of-the-mill pancreatic cancer that we hear every day on television, on those ads for awareness of pancreatic cancer. That just goes to show that despite the yeoman's work that Rob and Marianne and the CCAN group and the NANETS group are doing, there's still a lot more to go as far as awareness in the neuroendocrine tumors. Everybody on the streets heard of pancreatic cancer. I bet you half the people you come across have never heard of a neuroendocrine tumor or carcinoid cancer. We've got a lot more work to go. And despite that, the true incidence and prevalence is still probably underestimated. That's because the diagnosis is not made usually until late in the course of the disease when symptoms occur. And we know that because in autopsy findings, just random autopsy findings, there's a significantly higher frequency of neuroendocrine tumors than we've suspected in the general population. So the World Health Organization classifies NETs by certain diagnostic factors. We try to decide who's going to have a good prognosis, who's going to have a poor prognosis. Good prognosis patients have well-differentiated tumors. Their biologic behavior is what we call a low malignant potential, however, still malignant. These patients tend not to present with metastases. They have a low Ki-67 index, which we'll hear about later. It is an index of the proliferation of the tumor, how quickly the tumor is dividing. These patients have a low incidence of angioinvasion, that's invasion into blood vessels or infiltration into nearby structures. And tumor size is generally low. The patients with a poor prognosis have a poorly differentiated tumor. They have a high malignant potential. They usually present with metastases. The Ki-67 index or the proliferation index is usually high. And these patients do have evidence of infiltration and invasion into nearby blood vessels on microscopic evaluation. They can be of any size. Even small tumors can have a high malignant potential. So this is clearly associated with survival. The well-differentiated patients with well-differentiated tumors do better. Patients with poorly differentiated tumors do worse. And patients who have metastatic disease, those patients who present with disease outside the local area of the tumor, do worse. So patients who have only localized disease in the immediate area where the tumor developed, those patients have a better survival. The patients who have spread to local structures like lymph nodes in the immediate area of the tumor have an intermediate survival, and the patients who have disease that have spread to other organs have a lower survival. The big problem we have is that almost a third of our patients are metastatic at the time of diagnosis, and therefore those patients have a poor prognosis. And that's where we really have to make better progress. We have to try to diagnose patients at earlier stages before they spread, before the tumor spread, and so we have a fighting chance of getting the tumor out and increasing survival. Now, how different are neuroendocrine tumors from other cancers? Truth of the matter is they're not that much different. Yes, symptoms are a little different because of the peptide production, but survival-wise, a poorly differentiated neuroendocrine tumor has similar survival as a lung cancer. A well-differentiated neuroendocrine tumor has survival similar to that of prostate cancer, which we know is a slow-growing tumor that affects elderly males. So the overall survivals are not that different from other cancers. So what have we learned? NETs are malignancies. They are cancers. They arise in cells that normally produce peptides. Some neuroendocrine tumors are classified as carcinoid tumors depending on the peptides that they may produce. The incidence is increasing for various reasons. Most NETs are GI tract origin, and even small tumors can be metastatic, and survival even in metastatic NETs is similar to other late-stage cancers. How come we can't diagnose patients earlier? Well, these are some of the symptoms that patients with neuroendocrine tumors can present even early in their disease. Telangiectasias are small growths of blood vessels, facial flushing, wheezing, nonspecific cardiac disease, cyanosis, a little bluish coloration of the fingernails, diarrhea, abdominal discomfort, arthritis, rash. What does that tell a general doctor? Not that much. What do you look for? Almost anything. You could see these same symptoms in women that are going through menopause, inflammatory bowel disease, food allergies, asthma, thyroid disease, ulcer disease, and even run-of-the-mill anxiety. So we need to think of the diagnosis. And just like Rob said, when a doctor sees a patient, we think of common diseases. Common diseases, we're taught, common diseases occur commonly. Uncommon diseases occur uncommonly. What's wrong with that thinking is that neuroendocrine tumors are more common than we previously have thought. Again, the problem is NETs, patients with NETs are asymptomatic until metastatic. Some patients with NETs that have local disease that's growing just where the tumor started or involving local lymph nodes, can have vague symptoms just related to the tumor mass, to that growth itself in that given anatomic location. So that can cause those vague abdominal symptoms, bowel obstruction, or even jaundice if there's a pocket of lymph nodes blocking the bile duct, or if it's an appendiceal, a gallbladder carcinoid. Systemic symptoms are related to the peptides that are produced. So those can cause the carcinoid syndrome, which we'll talk about in a second, the diarrhea, glucagonoma, Zollinger-Ellison, which is a major ulcer type disease, and hypoglycemia. Briefly mentioned that almost a third of patients present with distant metastases. That's a big problem. So what is carcinoid syndrome? We've heard this term. Some patients have had carcinoid syndrome in this room. Carcinoid syndrome is a complex of facial flushing, wheezes, diarrhea, and in some patients, right-sided heart failure. Carcinoid syndrome occurs in anywhere from 8 to 35% of patients, and usually occurs in patients that have had hepatic metastases. And the reason for that is because when these peptides, or if these peptides are produced by tumors and they're released in the circulation, the liver generally metabolizes these peptides and could deactivate them, so to speak, and you won't get the symptoms from that. So you need the peptides the peptides need to escape metabolism by the liver or bypass metabolism by the liver in order to be symptomatic. So if the disease has a metastatic deposit in the liver, it's going to escape the circulation beyond the liver and then cause symptoms. Again, manifestations: flushing, wheezing, diarrhea, and heart disease. Okay. So as a clinician, how do we approach the diagnosis? History and physical exam. I always ask my patients any facial flushing, cramps, diarrhea. The diarrhea is very interesting. The diarrhea for carcinoid patients is a secretory diarrhea. That means it's not related to food intake. It's not related to the time of the day. And the typical question that should be asked by clinicians is, do you get diarrhea at night? Does it wake you up? Do you have to run to the bathroom at night with the diarrhea? We use various blood tests: chromogranin A, urinary 5-HIAA, and other biomarkers. I also get a serum serotonin level. Imaging. We've all heard the Arctria scan, the famous Arctria scan. Arctria scan is a functional scan. There are two types. I classify scans as two types: functional and anatomic. A functional scan will tell you if there's an area in the body that is secreting a substance related to the cancer, or metabolizing a substance related to the cancer. It will tell you if a growth is biologically active in some form. An anatomic scan tells you if there's something there, a picture, but doesn't tell you if it's functionally active. Okay. An Arctria scan is a functional scan. A CAT scan and a MRI are anatomic scans. Okay. Endoscopic ultrasound is used for PNETs, and I don't use PET scans in general for carcinoid tumors. So once the index of suspicion is raised, or a doctor considers the diagnosis of a carcinoid tumor or a neuroendocrine tumor, I get a panel of blood tests, and I send patients for the appropriate scans. CGA, chromogranin A, is a specific and sensitive test. However, it does have some limitations: gastritis, renal dysfunction, and most important, proton pump inhibition, PPIs, such as Nexium, a classic one, will give false positive results. And just this week, I got a call from an oncologist on Long Island that said that she wanted to ask me a question about a patient that had a localized carcinoid tumor resected, and then 2 months after, they've noticed that the CGA is still elevated. And the first thing I asked the doctor was, give me a list of the medications, and the patient was on Nexium. So and the patient, of course, was asymptomatic, and all scans were negative after the surgery. So first thing I did was tell the doctor, take the patient off Nexium. You can substitute old-fashioned Tagamet and repeat the levels in at least 1 month later, and it may take as long as 3 months for the levels to come down. But just because the CGA is elevated does not necessarily mean there's active disease. There may be other factors. Now, if there are no other factors and everything else has been eliminated, the CGA is a very good test to monitor treatment response. And I have had patients with CGAs in the tens of thousands and on treatment have come down. CGA has a very good correlation between tumor burden. You can have a CGA level in the tens of thousands in patients with a lot of liver metastases. And the prognostic value is really excellent for CGA. If a patient has an elevated CGA and there's an increase from the baseline, there's disease progression. A decrease usually indicates a response. What is 5-HIAA? I'm sure most of the patients have had a 24-hour urine collection for 5-HIAA. It is a metabolite of serotonin. It is a good screening test because it is unaffected by the time of day of a serum serotonin level. However, it still can be affected by some of the food and medications that can affect a serotonin production. I generally use a 5-HIAA in the beginning when I first see a patient, to get a baseline. If it's elevated, I'll occasionally follow it, but it's a lot easier, quite honestly, just to do serial serotonin levels, which is a blood test, than have patients keep collecting 24-hour urines, although it still is a very important test. And some of the foods that can affect both a serotonin and a 5-HIAA level are bananas, avocados, plums, tomatoes, pineapples, walnuts, and patients that have these, that are being tested, should be advised by their doctors not to ingest any of these foods for at least 24 hours before the test. I mentioned Ki-67 before. It is a very good cellular marker for proliferation. The test is done on the biopsy. It is not a blood test, done on the biopsy. It's used to determine the rate of tumor cell growth, and a high Ki-67 index indicates a more aggressive tumor, usually present in the more poorly differentiated tumors. And usually it portends a poorer prognosis, and patients whose tumors have a high Ki-67 will more than likely not require more aggressive therapy. And we'll skip that. We'll skip that. Just briefly, because I know the other doctors are going to be talking about this, this is what an octria scan image looks like. As you can see, it kind of looks like an ink blot test. It doesn't give you an accurate size of the tumor. It doesn't give you a definitive location. It gives you a general area of the cancer. It is a functional scan. So it will tell you where there is some functional tissue. Then an anatomic scan will tell you more of the size and location of the growth. Those anatomic scans, such as a CAT scan, and you could see, hard to see on this, but there are some liver lesions here on both the CAT and the MRI. So the diagnosis of NETs is difficult. Patients may be asymptomatic, especially in early stages of disease. It takes a while for patients' diseases to become ripe enough for us to diagnose. But an increased index of suspicion could shorten the path to diagnosis, and that will certainly help with treatment and survival. The markers that are important are serum CGA, urinary 5-HIAA, and serum serotonin. We also use some other tumor markers as well, neuron-specific enolase and pancreatic polypeptide. The octria scan is highly sensitive. imaging for functional carcinoids. Carcinoid crisis was a major cause of morbidity and mortality in the past. Not so much anymore because of a heightened awareness in carcinoid patients and what a carcinoid crisis can lead to and how to prevent a carcinoid crisis. So we don't see it as much as we had in the past. Some of the newer therapies enable us to control the tumor better, and hopefully this will eventually lead to our holy grail, the cure. Right now, we focus on, of course, symptom control. Very, very important. We have to control the diarrhea. We have to control the carcinoid syndrome. Uncontrolled diarrhea can lead to electrolyte problems, dehydration, weight loss. So these things have to be controlled. We're going to talk, some of the other doctors are going to be talking about how we control these symptoms and how we treat the tumors. And that concludes my talk on neuroendocrine tumors. I'm going to take 5 minutes to talk my pet peeve every year and talk about what's happening to cancer care and what's happening to cancer care in the community, which is where I do my work. We've seen cancer care change dramatically in the last 30 years. I would say that 30, 40 years ago, most chemotherapy, most cancer care was given as an inpatient in the hospital. It had shifted some time ago to the outpatient community center. And that reflected in cost savings where the cost of inpatient care fell with a substantial decrease. It has been estimated in the past that over 90% of cancer care was given by private physicians in the community as opposed to medical centers or hospitals. Our cancer care delivery has been, with no exception, the best in the world. If you take every cancer group, every cancer diagnosis individually, and compare the survival rates in the United States to the survival rates in, let's say, England, where they have socialized medicine for many years, across the board, survival for each individual cancer has been better in the United States than England. What's been happening over the recent years is Medicare has changed payments for oncology care and decreased those payments significantly over the last 5 years. Medicare pays for 50% of cancer care. It also has a huge influence on private insurance companies. What Medicare decides this year, private insurance companies in general adopt the next year. Congress has not been able to change the trend of decreasing payments for cancer care. And I don't mean just payments to the doctors. I mean payments for your medications, payments for your nursing care, payments for equipment, etc. The smaller community practices where, as I said, over 90% of cancer care has been delivered to the community, those small community practices with ever-increasing overhead and smaller patient populations compared to larger clinics cannot handle the decrease in the payments. We can't cover those decreases. Some of those private practices are being bought out by the hospitals, and you've seen that on Long Island over the last couple of years. Many practices are in financial difficulty because they've had not a good hold on the overhead, etc., but also because of the decreasing reimbursements. Currently, we have a large Medicaid population in the United States. However, more states are under pressure to cut Medicaid coverage and provide a reimbursement. Now, why do I mention Medicaid? Because one of the hallmarks that Congress has been saying is that there is not coverage for Americans. There are systems in place right now for Americans to get coverage who can't afford it. New York State has a program independent of Medicaid, but Medicaid is also a federal program administered by the states for patients with low income to get care. These programs have been in place. The problem is many patients don't register for it. Florida has been cutting drug reimbursement steadily over the last few years, independent of Medicare. The 20% copayment is also becoming more problematic with patients who have Medicare and do not have secondary insurance. The drug costs, as you guys know, sandostatin, for example, costs thousands of dollars for each injection, and if you don't have a secondary coverage, that can amount to a nice few $100s for each injection, which can be quite burdensome every month. So there was a recent study that showed about 57% of the cost of drug administration was covered by Medicare. There are 172 private clinics closed. This was as of July 23rd last year. 323 practices were struggling financially, and 44 practices across the country were sending all their patients, not some, all their patients elsewhere to get treatment. Practices were being acquired by hospitals, and practices were being merged. This study was sponsored by COA, the Community Oncology Alliance. So, of course, healthcare reform is the big topic of conversation. There are some misconceptions about what's driving our politicians to reform healthcare. One misconception is coverage equals care. Your politicians are saying everybody should be covered. That's great. That doesn't mean everybody's going to get care. There will be 30 million new patients covered under Medicaid, because Medicaid is expanding. What healthcare reform wants to do is decrease Medicare, increase Medicaid. But Medicaid reimbursement is very, very bad, and many doctors don't accept Medicaid. Another misconception is doctors are inherently driven by profit. They think that the large integrated delivery systems are the most efficient. And they think that your GP needs to be the hub or the gatekeeper of medical care. I tend to disagree. I think many specialists would disagree that the hub for cancer care for a cancer patient should be the oncologist, not the GP. Oncologists are trained as internists first, and then oncologists. Another misconception is PCPs are less expensive than specialists, that they can coordinate the care less expensively. Fact of the matter is, they tend to order too many tests and unnecessary tests and redundant tests. So what is healthcare reform supposed to do? Well, healthcare reform is supposed to change the current fee-for-service and push providers to coordinate care, reduce duplication, and distribute payments in a more equitable fashion. Absolutely. Those are great. Healthcare reform is supposed to create a new entity called Accountable Care Organizations that's going to funnel all federal dollars, which currently include Medicare and Medicaid, but will eventually include all insurance, when the government takes over all insurance, and they will funnel all these payments through an ACO. An ACO will bundle and capitate payments because they have to cover more Americans. It's supposed to make businesses and individuals, it's supposed to make it easier for individuals and businesses to purchase insurance. It's supposed to increase the number of primary care physicians and ensure the quality of care, all through this ACO. That means the ACO, because they're in charge of the money and in charge of the care, is going to have to ration the care, because you can't slice the same pie into more pieces without decreasing the size of the pieces. The problem is the government itself says it's not going to work. The government's own actuary says that even with health care reform, spending was still going to grow. The cost of health care is still going to go up, but Medicare spending is going to go down. Patients are going to be pushed into Medicaid. Private insurance premiums are going to increase, and the overall out-of-pocket expenses will decrease because more individuals will be insured. But there are still some good things with healthcare reform. We definitely need healthcare reform. Some of the good things are that patients cannot be denied access to clinical trials, and routine patient costs must be covered. That means that if you're enrolled in a clinical trial, your insurance company, whether it's Medicare, Medicaid, or a private insurance company, must pay for routine care. They can't say, you're in a trial, we disown you. That can't happen. That's a good thing. There are going to be some new safeguards installed, and there's going to be some innovation centers to increase research money. All very, very good. More good things. It will overcome certain barriers to health care, especially cancer care. The Medicare donut hole is going to be decreased and eliminated. And preventive care services are going to be increased and covered in its entirety without co-payments. What are the bad things? Well, for cancer care itself, because of the decreasing reimbursements, especially for drugs, it's going to put more pressure on both the patient and the providers, the doctors. As it stands now, doctors do not make a penny on the drugs. And that's because a number of years ago, Congress instituted a new payment plan for drugs called ASP, average sales price, which means that the government pays the doctors back for the drugs basically at the cost of the drugs. There's a formula used, it's too complicated to go into, but that's essentially what it winds out to. You'll notice that your doctors have cut down on their staff or freezing staff, even though the offices may seem more crowded, patient volumes increasing. Some offices are sending patients elsewhere for treatment. This really uncoordinates patient care. It leads to inefficiencies. Believe it or not, when a doctor sends a patient to the hospital to get their treatment for cancer care, it costs more for the government. The hospital makes more money. The doctors obviously don't make any money. And it's inconvenient for the patient, and care becomes fragmented. Why do some doctors do that? Some doctors do that because it becomes a losing proposition in the office. We cannot handle it. Forcing care back to the hospital increases costs. When you consolidate, you decrease alternatives. So when practices merge or hospitals buy practices, alternatives decrease. There's less competition. If the hospital or a very large group practice is the only game in town, costs will go up because they can negotiate and drive up costs. what's happening to us, to the doctors, the oncologists? Cancer care, the demand for cancer care is going up, but the supply of oncologists is going down. Most of us are over 30 now, Tom? We're over 30? Oh, over 30. 39. And there's going to be a shortage of oncologists. And we've been seeing that for a couple of years now, right, Tom? Yeah. So what happened just this past couple of weeks with the budget crisis, our trillions and trillions of dollar budget deficit? Well, we had that 11th hour compromise with Congress. That compromise wasn't so good from a medical point of view, because it looks like it saved our government from shutting down. But the little known provision in there was that if in November, when the cuts in spending have to be identified and ironed out and written out, if it's not done, if those cuts are not done, there will be a mandatory decrease in Medicare payments. So, if the super committee cannot agree on spending cuts, or if Congress does not vote its approval by December, not November, there will be an automatic 2% cut to Medicare. Automatic. That's on top of the every year we always have these cuts to Medicare. So that's on top of it. Okay? Still unknown, but for now we think it's going to be a cut to both drugs and services related to oncology. That means the drugs that we make no money on now, we're going to lose money on. And that means that you're going to see some Medicare doctors who treat Medicare patients say to the patient, here's a prescription for your Sandostatin. I'll be happy to administer it to you. You go get it. Okay? Because no person in their right, no doctor who runs a business in their right mind can say, I'm going to buy this drug for $3,500, I'm going to give it to you, and I'm only going to get back $3,300 for it, and lose $200 every time I do it. You can't do that. The supermarket doesn't work that way. So, those cuts will be in drugs. ASP plus 4 means the drugs. It will be in diagnostic imaging. And those will be on top of the 29.5% fee reduction. That's the sustainable growth rate. We see that every year, and to be honest, every year Congress seems to make a one-year exception and delay it for a year. But if they don't delay it because of the deficit problems that we've had this year, that means 29.5% fee reduction, and then that 2% on top of it. So you're looking at over 30% fee reduction. Doctors are going to be dropping out of Medicare like flies. Okay. So what do we need to do? We need to work together. We are still your advocates. We still want to take care of our patients. We still want to give you the care that we've always given you over the years. We need to work together. We need to fight the politicians and let them know that medical care, cancer care is very important. We have to tell them what their job is, because politicians really think their only job is to get reelected. That's their job. They do it very well. We have to give them a new job. And that job is take care of their constituents, like we take care of you. If we don't, it's going to lead to poor quality, inefficiencies, and higher costs. We all need to be involved, and I hope you all will be. Thank you very much.